Okay, it's, it's 8:30 and we'll get started. Yusuf is sick or on quarantine, so he's not going to be here. So I'll introduce myself. I'm Paul Merrick, as you know. Okay, so today we're going to talk about ARDS, which is acute respiratory distress syndrome. So I don't have any disclosures. So the syndrome was first described in 1967 in this famous paper in The Lancet. I think they had their paper rejected a few times before it was finally accepted. So this is really a landmark paper by Petty and Asbach. So they described 12 patients with acute shortness of breath. They had an acute insult. They were hypoxemic. And they reported loss of lung compliance, and their patients were PEEP responsive. So those 5 points are really important because those really critical factors seem to have got lost with time, as you'll see, and really are quite important in understanding this disease and how to treat it. So like most things in medicine, you have to have a definition. So a bunch of people get together in some exotic place and come up with some definition. So this was the American European Consensus Conference, published in 1994, and they divided ARDS into 2 categories: acute lung injury based on the PaO to FiO2 ratio, and ARDS based on a PaO to FiO2 of less than 200. Patients had to have bilateral infiltrates on the X-ray, and you had to exclude cardiogenic pulmonary edema. And as you will see, these are very non-specific findings, and that's really the key to what we're going to be talking about. But it seems that that definition was inadequate, so then they got together again in Berlin and basically revised the definition. So it's pretty much the same, except they divided ARDS into 3 categories based on the PaO to FiO2 ratio of mild, moderate, or severe. So I've highlighted syndrome because really this is a syndrome, it's not a disease. So really, does the Berlin definition change anything? You know, is the real change or the emperor's new clothing? So really, there's no change in the underlying conceptual understanding. ARDS, which is an acute diffuse inflammatory lung disease leading to increased vascular permeability, increased lung weight, loss of aerated tissue, hypoxia, bilateral radiographic capacities, associated with increased venous admixture, increased physiological dead space, and again, decreased lung compliance. The lung compliance, they really didn't emphasize in their definition. So probably it's best to start on the pathophysiology of ARDS. So you have activation of alveolar macrophages and you recruit neutrophils. So this is really important. This is a neutrophil-mediated disease. So interestingly, patients who are neutropenic really don't get ARDS. And it's uncommon in typhoid because they have a low neutrophil count. So neutrophils are the major players of this disease. They then elaborate a whole bunch of bioactive mediators, proteases, reactive oxygen species, cytokines and chemokines, eicosanoids, phospholipids. They damage the type 2 epithelial cells, and we know what those are from COVID. You get loss of the endothelial barrier and accumulation of a protein-rich edema fluid in the alveolar. The alveolar get filled with fluid, you get interstitial edema, hypoxia, decreased lung compliance again, and physiologic shunting. So the important part is that histologically you get diffuse alveolar damage, or DAD. Okay, so this is a diffuse alveolar disease. So really it's important to recognize what ARDS is, because that often gets lost. Diffuse alveolar damage. And there's bidirectional involvement between the lungs and other organs. And the sequence of events depends what's causing it. So it can be caused by a pulmonary or an extrapulmonary cause. So basically here you have an alveolus. You can see on your left is a normal alveolus with alveolar macrophage. What happens with ARDS? Macrophage activation activates neutrophils, and neutrophils have all of these granules and release their toxic cargo of inflammatory mediators, damages the type 2 cells, interferes with the tight junctions. You get increased capillary permeability and vascular damage. There are some other pathways that may be involved. Release of mitochondrial components from damaged cells, so this may play a role in trauma. Activation of the ubiquitin proteasome system, and then neutrophil extracellular traps or NETs. So NETs seem to be becoming an important cause of inflammation. So they're related to neutrophils. So what happens is these bad neutrophils extrude their nucleus, and then the nucleus forms these traps made up of neutrophil nuclei. So generally, we talk about 3 phases. There's initial exudative phase, in which you have diffuse alveolar damage, a proliferative phase, and then some patients will then progress to the 3rd fibrotic phase. So the resolution of ARDS is an active process. The type 2 cells pump the fluid back into the vessels, takes place after about 5 days. There's a balance between repair and fibrosis, and occasionally fibrosis dominates, so you get a fibrotic reaction. So the risk factors, what causes ARDS? So you can have primary, which is primary lung damage, and you'll see the most common is pneumonia, aspiration, contusion, inhalation injury, and the secondary are sepsis, severe trauma, burns, multiple blood transfusions, pancreatitis, etc. And it should kind of be obvious that the pathophysiology would depend somewhat on the inciting event. So if you look at the commonest causes of ARDS, so this was an epidemiological study done in ICU in 50 countries, the most common reported cause is pneumonia, 60%. So we're going to talk at some length about that, because whether it's pneumonia or whether it's ARDS is somewhat important. And most people, including Dr. Flemmer, probably don't distinguish between the two, and it becomes important. And then you have other causes such as aspiration, blood transfusion, and trale inhalation. But you can see that the 2 commonest causes are pneumonia and extrapulmonary sepsis. And as we said, the Berlin definition had broken down it into mild, moderate, or severe based on the PaO to FiO2 ratio. So this is the probability of hospital survival. And you can see obviously depends on the severity. So if you have severe ARDS, you have a 40% mortality, and that's still with the best of care. So it is a disease that is serious. So their conclusion amongst the ICUs in 50 countries, the period prevalence was 10.4% in ICU admissions. We'll come back to that. This syndrome appeared to be under-recognized, under-treated, and associated with a high mortality rate. These findings indicate the potential for improvement in the management of patients with ARDS. So the point prevalence was 10.4%. So anybody who's rounded in our ICU will say Well, we don't see ARDS, which we don't. We may have 1 or 2 cases a year, and these get imported from other hospitals. So how can that be? So we'll talk about that, because I think that's important. When you go to other hospitals, you most definitely will see ARDS. But in our ICU, it's vanishingly uncommon. So why is that? And we'll talk about that. So the other thing is that not all ARDS is the same. As we said, this is a syndrome. So if you have ARDS due to trauma, your survival is significantly better than if you have ARDS due to pancreatitis. So again, to emphasize, this is a syndrome. The other thing to emphasize is most people think the patients die of uni-organ, single-organ respiratory failure. But as you can see, the most common cause of death is multi-system organ failure, because this is a diffuse inflammatory disease, and what's happening in the lungs is happening in many other organs. So one of the ways you can quantify quite simply the severity is this severity scoring system. Basically, you divide the lung into 4 quadrants, and then based on how extensive the infiltrates are and how dense they are, you can give it a score, and you can quickly come up with a score which does have some bearing on the prognosis. So it's a neat little scoring system. So the question really is, what is ARDS? So by definition, this X-ray meets the criteria bilateral infiltrates of acute onset. But as you'll see, that doesn't really mean you have ARDS. So what we really need to do, and Luciano Gattinoni, so he's a very interesting Italian, smokes a big cigar, lives in Germany. He's kind of the pioneer on ARDS, and what he did is he had a CAT scanner in his ICU. Can you imagine such a thing? It makes sense. You have a CAT scan in your ICU. So what he was then doing is CAT scanning all these patients with ARDS, and he made these really important conceptual discoveries, and he called it the baby lung or the sponge lung. So first you can see on the left, this is CT going from apex to mid to down, that this is predominantly a dependent basal disease. But then what he did, which is very cool, he flipped the patient. So you see that's supine, and you see the dependent airspace disease. Now the patient is prone. And what happens to the dependent airspace disease? It moves. It moves. Okay. And then he flips them back again, and it moves again. Okay. So that is classic of ARDS. And you think about it, if this is due to basal pneumonia, which you have consolidated dense lung, the infiltrate's not going to move. So why does the infiltrate move? So that's where the sponge lung comes in. Now, I'm sure you've all been in a bath and played with a sponge. Now, what happens when the sponge gets wet and takes in fluid is the dependent part of the sponge kind of collapses because of the weight of the sponge above it. But you flip the sponge over, the dependent part gets consolidated again. So really what you're doing is you're having edematous wet lung, and the collapse is due to the weight above the lung. That's why it's dependent. And that becomes really important in understanding how to treat this disease. And clearly, if you have dense consolidation, you're not going to move. And that's such an important concept. So again, we have another study by Gattinoni. So the top 2 panels are patients who supine, and expiration and inspiration. So you see, if you blow up the lung, and expand the lung, you just blow air into it, you recruit the lung and you open the alveoli. Again, suggesting that these are not densely consolidated lungs. These are lungs that you can recruit with airway pressure. And again, the bottom slide shows exactly the same thing in a prone position. So again, the infiltrates move and are recruitable. So that's really fundamental to understanding how to treat this disease. So we can see again, he's a smart man, Dr. Gattinoni. Maybe it's all the spaghetti he eats. So what he did is he took these patients and he used increasing airway pressure. Now, you're not going to do this in a patient, but you can see he increased airway pressure to 60 centimeters. Now, that's really high. You're going to blow up the lung. But as you can see, as he increased the pressure, the infiltrates disappeared because he's expanding the alveolar and pushing the fluid out. So he's increasing alveolar pressure. We'll wait for questions towards the end. Thank you. Yeah, so we will talk about acute ventilator-induced drug injury. So that is a good question. So what I'm saying is this is an experimental model. Okay, so I'm not suggesting, it's a good question. I'm not suggesting you do this because high pressures damage the lung. It's just an interesting physiological experiment to show that you can recruit lung. But this is not something you want to do. So, are these the same disease, severe pancreatitis and community-acquired pneumonia? So that's really the gist of what I'm trying to get at. So this is a real patient who was in the ICU. She was a 32-year-old female. She was immediately status post-delivery. So what is this? Because what it is determines how you treat them. You have to understand the disease to treat the disease. And if you treat a disease that you think the patient has but doesn't have, it's not going to be helpful. So is this CAP or is this ARDS or is it both? Yeah, so I mean, they're bilateral infiltrates, it's acute onset. So if you use the French American or the Berlin definition, by definition, this is ARDS. Bilateral infiltrates, acute onset. However, this was her CAT scan. Okay, really important. This is not the CAT scan of someone with ARDS, which we said was dependent airspace consolidation due to the weight above it. This is bilateral dense pneumonia. Okay, bilateral dense pneumonia without ARDS. So the distinction becomes really important in how you treat these patients, as you'll see. Because if you try and blow up the lung, like Dr. Flemmer was implying, what you're going to do is you can't recruit this dense consolidated lung. It looks like the liver. What you're going to do is you're going to expand the normal lung, the unaffected lung, the lung that doesn't have ARDS. You're going to overinflate the lung. You're going to cause barotrauma, and you're going to damage the unaffected lung. So that's why it becomes critical in deciding, is this bilateral pneumonia, or is this ARDS? So in fact, what we did with this lady is we treated her like bilateral pneumonia. We didn't use high PEEP or high inflation pressors, and she got HAT therapy. And if you don't know what HAT therapy is, let me think. Hydrocortisone, ascorbic acid, thiamine. And that was her x-ray after 48 hours. Okay, so to kind of validate what I'm saying, this was an autopsy study of patients who so-called had ARDS. And you know, the pathologist is smart, they know everything, but it's after the fact. So what they say in the study, as we said right at the beginning, ARDS is defined as diffuse alveolar damage. It's a widespread disease. Pneumonia is a common cause of ARDS, but not all pneumonia causes ARDS. And what they found is there was a significant discrepancy between what they found on autopsy and the clinical diagnosis. So many patients had neither signs of DAD or infection. The kappa agreement coefficient was quite poor. So it again is confirming basically what I'm saying, is that the definition of ARDS is a really bad definition. It doesn't tell you anything. So you all may have heard of COVID, maybe or may not, it's somewhat in the news. So people think COVID is ARDS. This is not ARDS. Really important, because in New York City, they were treating these patients as if they had ARDS. They were intubating them and treating them as if this was ARDS. The mortality in New York City, if you were put on a ventilator, was 88%. Why did they die? Because they were treating patients for a disease they did not have. So if you look at this CAT scan, you can clearly see this is not ARDS. There's no dependent airspace disease. The pathophysiology of this disease is an organizing pneumonia. So if we go back to Petty's definition right at the beginning, okay, these patients, if you actually measure their compliance, they have normal compliance. So patients who present have normal compliance. They are not PEEP responsive. This is not ARDS. It's really important. So this is, again, COVID organizing pneumonia. You can see it looks nothing like those CT scans I showed you from Dr. Gattinoni. You have this peripheral ground glass opacifications that do not look like ARDS. They don't move like ARDS. The patients have good lung compliance and are PEEP non-responsive. Okay, so the Berlin definition is clearly completely silly. So how can we improve the diagnosis of ARDS? And yes, we can. Because what you can do is you can actually measure extravascular lung water. We can do this clinically at the bedside. And as we said, the definition of ARDS is alteration of capillary permeability, exudation of this fluid. So you have fluid in the lung, similar to pulmonary edema. So we have technology in ICU. It's quite simple, actually. It's very minimally invasive. It's called transpulmonary thermodilution. We put a catheter in the femoral artery. They need a subclavian or IJ, and then using a process called transpulmonary thermodilution, we can actually measure lung water. The physics is somewhat complicated, but as you'll see, it's pretty accurate. You can measure what's called extravascular lung water. This is the water in the lung. So this is a validation study where they measured extravascular lung water in an oleic acid model, which causes ARDS, and a pulmonary edema model, and found really good correlation between transpulmonary thermodilution and the gravimetrics method. We actually weigh the lung. So this is a truly interesting study from Japan. So apparently in Japan, you can take out a person's lung after they die without informed consent. You can just do it. So what they do is they monitor patients' lung water, and then the moment they die, they whip out their lungs, and then they measure them, they weigh them. And in this way, you can see the weight of the lung or the extravascular lung water in those with normal lungs and diffuse alveolar damage. So they've showed pretty clearly that extravascular lung water is a very sensitive way to diagnose ARDS. And if you have a lung water greater than 10, that's increased. If it's greater than 14, it's diagnostic of ARDS. Now, obviously, your lung water will go up with cardiogenic pulmonary edema. So there are tricks to be able to distinguish based on a number of parameters whether this is more likely cardiogenic or non-cardiogenic. But obviously, it tells you you have pulmonary edema. So it does depend on the clinical context, and there are some parameters you can look at which help you distinguish, which largely has to do with the capacity of the different ventricles. So when we look at extravascular lung water in the ICU, you can see as the lung water increases, the mortality increases. So it's quite sensitive. This was a study, again, looking at lung water in patients with sepsis, with increased or decreased lung water. And you can see it's not a mystery. This is probability of survival. If you have a lung water less than 10, your mortality is quite low. So we'll see the determinant when you're septic of high versus low lung water is because what you do. You give too much fluid, called the Franzi method. You cause the lung water to go up. You cause severe edema. The patient dies. We now have extensive evidence that increasing fluid increases lung water, increases organ edema, and increases risk of death. So this was a commentary by Dr. Perel after the Berlin definition, and basically he's saying that extravascular lung water and what Dr. Flemmer was talking about, the pulmonary permeability index, which gives you an idea, is this due to a permeability problem or hydrostatic problem, improves the definition of ARDS. Now, probably the reason they didn't include this in the definition was because it's pretty sophisticated technology, which is not really accessible in developing countries. But still, I think it highlights the limitations of the current definition, the Berlin definition. So as an example, I'll show you this patient. So she's morbidly obese. As you know, in this area, we have a pandemic of obesity. She had pneumonia. She had so-called severe ARDS. She had acute renal failure. And she was one of those patients who was transferred to us from Scary View Hospital. So that's her x-ray on the left. She came on FiO2 of 90% and 22 PEEP. So these were her hemodynamic profile, okay? Her CVP was 30, but notice her extravascular lung water index was 21, okay? So she was grossly volume overloaded. So it's a condition called iatrogenic saltwater drowning. Okay, so this is a form of drowning that is quite common in hospitals. So although they're not in the ocean, they are drowned with salt water. So what did we do? We took fluid off. Okay. So she was on CVVH, we removed fluid. So you can see her extravascular lung water went from 21 to 12. And despite taking off fluid, the cardiac index stayed stable. It didn't go down, it went up somewhat. So you can see her lung water went down, and now she's on 40% in APRV. APRV, as we've come to, stands for airway pressure release ventilation. And it's actually a very efficient way of getting rid of lung water. It's a cool little trick. So by changing her mode of ventilation and taking off fluid, we could normalize her fluid status, improve her oxygenation, and then she got extubated. So this is a study looking at lung water in patients with sepsis, with ARDS, and those patients who are septic without ARDS. And the big difference was lung water. And why was their lung water increased? Because of folks like you indiscriminately giving fluids. It's really important. Okay, you give fluids to people who are volume depleted and people who are dehydrated. Patients with sepsis are neither volume depleted or dehydrated as a general rule. So this bizarre idea of giving fluids to fill the tank fills up the lung. So the question is, and obviously the answer is yes, is ARDS an iatrogenic disease due to healthcare practitioners flooding patients with fluid? And the physiological basis is kind of obvious. So this is the pulmonary capillary pressure and extravascular lung water. So you see the bottom is normal, but as your lung permeability increases, your ability for fluid to go out and for developed lung water goes up. So people who have abnormal capillary permeability, if you increase their pulmonary hydrostatic pressure, they're going to develop heightened leakage and extravascular lung water. So that was just the introduction. So what's the problem in ARDS? Thickened diffusion membrane, as we said, inflamed alveolar, collapsed bronchioles, loss of elasticity, massive shunt, and severe hypoxemia. Now, obviously, this is very different from COVID. So what is the basic management strategy? Obviously, identify and treat the underlying cause. The most important strategy is a lung protective ventilatory support strategy, which we'll talk about and Dr. Flemmer alluded to. Third, the application of PEEP, because PEEP recruits lung. But obviously, it's only going to recruit lung if you have ARDS. You want to have a conservative fluid strategy because, as we said, the more fluid you give, you increase hydrostatic pressure, the more leaking you get. You want to prevent complications. You don't want to overfeed. You don't want to oversedate. You want to do spontaneous breathing trials. You want to treat them with steroids and HAT therapy. So because ARDS is quite common, as you saw from those previous slides, there have been a host of studies done to try and change the course of this disease. And as you see, there are probably over 40 different studies, somewhat highlighted on this slide. However, we need to talk about this study. Okay, published in 2000. So for some of you, that's really long ago, maybe prehistoric. This is probably the most important study ever done in critical care medicine. It's very important, okay? So this is the ARDSnet high versus low tidal volume study. Very important study. Because there are not many randomized controlled trials in critical care medicine that actually show doing something makes a difference. This is one of them and it's been validated multiple times. So they took patients who had ARDS, 860, and they randomized them to two groups, 6 cc's per kilogram or 12 cc's per kilogram tidal volume. So many detractors, people like to find fault with studies, say that 12 cc's was not the standard of care and that was ridiculous. But I can tell you when I was a resident, and that was before the Great War, there was the rule of 12s, a rate of 12, a tidal volume of 12 cc's per kilogram, and a PEEP of 12. So that's what we actually did. So what they did in this study is they compared what we used to do versus 6 cc's per kilogram, and that was based on a lot of animal data showing that high tidal volumes and high stretch actually causes the disease you're trying to prevent. Really important. that overdistension of alveoli causes barotrauma and causes an inflammatory response and causes ARDS. They used this PEEP table, which they kind of came up with empirically, which as it so happens has stood the test of time. And what they showed is that the use of low tidal volume reduced mortality from 39% to 31%, so significant reduction in mortality. And since then, low tidal volume is considered the standard of care. And this doesn't matter if you intubate the patient in the emergency room. This doesn't matter if you're in the operating room or in the ICU. You should be ventilated with a tidal volume of 6 mL per kilo. And what they found is that if you look at mortality, so that's dead people, and plateau pressure, the higher the plateau pressure, the higher the mortality. So clearly you want to keep a low plateau pressure. However, doing really fancy mathematical modeling, they found actually that the most important factor determining lung injury, so we said high tidal volume damages the lung, is the driving pressure. So it's the difference between PEEP and your high pressure. The driving pressure was the best factor in predicting lung injury and outcome. So generally what they found is, you can see from this graph, you want a driving pressure of less than 16 centimeters. They then did the FACT trial comparing two fluid strategies, a very complicated study, but basically showing what is kind of obvious. Sometimes you have to prove the obvious. If you use less fluid associated with better oxygenation, improved lung injury score, and patients with less stay on the ventilator. So I think those two studies established the standard of care: conservative fluid, low tidal volume. So there have been a whole host of advanced strategies which we need to look at. So there was this study which they said, okay, let's recruit the lung and then let's use high PEEP. And they compared that to a low PEEP strategy. And in fact, what this did is it increased the risk of death. So if you use this high PEEP strategy, you actually knocked off some patients. So why would that be? And it's for what we said, because these patients are ARDS, so-called. They're going to be a whole group of patients that have non-recruitable lung. And then what you're going to do is you're going to increase and hyperinflate the normal lung. So you're going to damage the normal lung and cause ARDS. And that's exactly what happened. So you have two groups of people, patients, some who have recruitable lung and some who don't have recruitable lung, which kind of goes back to what we say is ARDS is a disease, diffuse alveolar damage with recruitable lung. And that's why the definition is important, because if you try and treat them with high PEEP like they did with COVID, you're going to kill them. So there's a mode of ventilation called airway pressure release ventilation, which is kind of cool. It's the inverse way of actually breathing. So when you take in a breath, you breathe in and then you breathe out and you keep it out. What this does is it keeps the breath in, and then you have intermittent exhalations, and then you're back again. So it's a way of keeping the lung open. It's called an open lung approach to recruit the lung. Now, obviously, this is only going to work if you have recruitable lung. So if you try this on a patient with COPD, they will no longer have COPD because they'll be dead. So you have to apply this appropriately. The advantage of APRV is it allows the patient to breathe spontaneously throughout this whole business. So there have been a number of studies and meta-analyses, which basically the top panel is ventilator-free days, the bottom is mortality. So there seems to be a benefit. This is a more recent meta-analysis, again showing a mortality benefit from APRV ventilation. The people tried this high-frequency oscillator. So there were these oscillator ventilators which went like, oopsie, They went like crazy, backwards and forwards, and through complex physics, they thought by bulk flow, it will improve oxygenation. However, there were 2 studies done which actually showed that it was harmful. So then we go on to neuromuscular blockers. So this was the idea that you paralyze the patient for 48 hours to allow easier ventilation. And this was a study from France and showed an improvement in outcome with neuromuscular blocking. They would use cisatracurium. However, there was then a follow-up study, again done by the ARDS network, which showed absolutely no benefit of paralytic agent. So the bottom line is we don't use paralytic agents unless we're forced to. Often we'll do it acutely just to stabilize the patient, but we try and avoid neuromuscular blockers. Then what about prone positioning? I showed you that when you flip the patient, you actually move the infiltrate. And it so happens that if you breathe lying on your stomach, you actually improve ventilation perfusion mismatch, facilitates draining of secretions, and you get less lung collapse. So it's kind of odd, but patients benefit from proning. So that's why with COVID, what we do is we put them on high-flow nasal cannula, and we do proning. Really called cooperative repositioning. So they lie on their stomach, they lie on their side, rather than lying on their back. And that helps to improve oxygenation. And there was this study which clearly showed a mortality benefit. So just the way you nurse the patient makes a difference. It's pretty cool. Obviously, the problem with proning is if you have massively obese patients, it becomes somewhat of an issue. So what about ECMO, which is extracorporeal membrane oxygenation? So there was the Elolea Study, sorry, it's a mouthful, in which they randomized patients to control or ECMO. You can see these people were pretty sick, PaO2 FiO2 ratio of in the 70s, reasonably high peak. And what they found is there was a trend towards improved outcome in the ECMO group, 65% versus 54%. However, it did not reach pre-specified thresholds for continuing, and the Data Safety Monitoring Board stopped the study at that point. Now, as you'll see, that was a bad thing because it was not statistically significant. The p-value was 0.07. If they had randomized another 20 or 30 patients, it would have been significant. So the NEJM, published this little story about learning from a trial stopped early by a data safety and monitoring board. So sometimes one has to use common sense rather than statistical hijacking. So you either have believers or non-believers. Based on the Elolea trial, some people will say, yeah, it was positive. Some people will say it was negative, really based on their interpretation of ECMO. You'll see how we think it fits in. So basically, you need a stepwise approach to ventilation. So you first start off, is this ARDS? If this is ARDS, you want a lung protective strategy, increasing FiO2 and PEEP. You want to have conservative fluid management. So this is our standard ventilatory technique. Okay, if this fails, then we do APRV. If APRV fails, it doesn't work, we do prone positioning. And if prone positioning doesn't work and the patient's a candidate, we would consider ECMO. So you can see the stepwise approach. You don't want to just jump in with ECMO. You want to try these alternative techniques first. So there have been a whole host of pharmacological therapies which have been attempted to treat this disease. And as you can see, most of them have failed, maybe because of poor trial design. One of the more interesting drugs is statins. So this is the simvastatin study, which basically showed a trend towards improvement in the simvastatin group. Here, p-value was 0.09. But because it didn't meet P05, people say it's a negative study. What they then did is they divided patients into different groups because it's clear that this is a syndrome. So they divided patients into two phenotypes, a hypo-inflammatory and a hyper-inflammatory phenotype, based on really some clinical criteria. And the postulate was that statins have anti-inflammatory properties, would most likely work in the hyper-inflammatory phenotype, and exactly that's what they showed, improved outcome in the hyper-inflammatory phenotype. Now, talking about COVID, because that's on everyone's mind, there is actually data now that 3 or 4 observational studies is that patients who are on a statin, particularly atorvastatin, do have a reduced risk of death, presumably because of the anti-inflammatory properties. We don't like simvastatin because it has a whole host of drug interactions. It's a whole host. So we don't recommend simvastatin. And then what is really interesting, Dr. Flem is quite smart, is that statins have antibacterial properties. So they are antibiotics. Not only are they anti-inflammatory, not only do they promote resolvins and the repair of inflammation, they have antimicrobial activity. So if you look at the MICs of atorvastatin compared to the other statins across a whole host of microorganisms, atorvastatin has a lower MIC. So it's another reason why you want to use atorvastatin versus the other statin. So this may be the reason that people on statins who get septic do better. It may, because part of it is the anti-inflammatory, but it may also be the antibacterial properties. I wouldn't suggest using statins in place of antibiotics, but this is an adjunct. So we then need to talk about corticosteroids. So people have a significant bias against steroids, presumably because these are cheap, readily available drugs. So this was the artsnet corticosteroid study, which was supposedly a negative study compared to the tidal volume and fluid management strategies, which were labeled as positive studies. However, one of the most significant endpoints in ICU patients is something called mechanical ventilator-free days. So that means you're off a ventilator and you're alive, okay? Which is a good thing. So patients want to be off the ventilator and alive. So you can actually see that the number of ventilator-free days was significantly better with steroids, the Lazarus study, than with the other two ARDSnet studies. So to call this a negative study is absurd. The problem with the study was that patients who got steroids after 14 days appear to have an increased mortality when they got steroids. However, if you looked at the patients, they were significantly sicker. There was a sicker group of patients. So if you did statistical adjustment based on severity of illness and other factors, there was actually no difference in mortality. And indeed, we have a more recent study, 2020, so I think it's this year. So this was an Italian group. They took patients with ARDS. They gave them dexamethasone, 20 milligrams for 5 days, and then 10 for 5 days. So this is again relevant with COVID. So remember in COVID, they used 6 milligrams a day, which is, you could rub it on the umbilicus, okay? It's not an effective dose. So they used a better dose. The other thing is that methylprednisolone penetrates significantly better into the lung than dexamethasone. But still, it's a steroid and has anti-inflammatory properties, and what they showed is an improved survival with dexamethasone. So again, supporting the rationale of using corticosteroids in patients who have lung inflammation like ARDS and the respiratory phase of COVID. So what about vitamin C? So this is the Citrus ALI study in which they randomized patients with ARDS due to sepsis to vitamin C or placebo. The primary outcome point was the SOFA score. So you see on this graph, it made no difference. But as we'll discuss, there were a lot of shenanigans we'll talk about. Generally, shenanigans are quite bad. So you look at mortality. So most patients are really not interested in ventilator-free days or SOFA score. They want to know, are they going to live or die? And you can see that there was a significant reduction in mortality with vitamin C. Nevertheless, the editors and reviewers of JAMA called this a negative study, even though there were more survivors, because the primary endpoint was negative. However, you can use statistics to obfuscate the truth. And I think we know now more than ever that the truth really is important. So what they did in this study, what they were forced to do, is when they calculated the SOFA score, they excluded people who died. Now, obviously, then you are actually filtering out people who were alive. Okay. So when they recalculated the SOFA score using what's called the worst rank, best rank score for including all patients, because obviously patients who survive are going to do better than patients who died and would influence the score. When they recalculated the SOFA score, you can see there was a significant decline in the vitamin C group as opposed to the placebo group. So therefore, both the primary outcome of SOFA score and the secondary outcome of mortality were positive. Despite that, the editor and sub-editors of JAMA consider this a negative study. So what do we say? Patients with ARDS, you want to treat them with steroids and vitamin C. It's not rocket science. So this is an interesting paper. It's called The Effect of Interventions on Survival in Acute Respiratory Distress Syndrome, an umbrella review of 159 published trials and 29 meta-analyses. And basically, what do they show? They show basically what I've told you. We're not talking about the steroids because that's reasonably new. Two major interventions which reduce mortality: prone positioning and low tidal volume. Their conclusion: there's limited supportive evidence that specific interventions can decrease mortality in ARDS, while low tidal volume and prone positioning in severe ARDS seem effective. Most sporadic findings of interventions suggesting reduced mortality are not corroborated consistently in large-scale evidence, including meta-analyses. So this was done in 2014. So I suppose, based on more recent evidence, one would have to include corticosteroids together with low tidal volume and prone positioning. So I thank you. We have some time for questions. You can ask a question on anything. Yep. Yes. Yes.